Our next presenter is Mohammed Mazlan from Malaya Manipal Medical College. Also, Nur Shafika, my apologies, you're from Sagi University.
1, 2. Touchscreen? No. A very good evening, everyone. First and foremost, thank you so much, MMI, for having me here today. I am Mazlan Muhammad Musaddiq, representing Malaya Manipal Medical College, and today I will be presenting a case report on the therapeutics of splenic marginal zone lymphoma complicated with mixed autoimmune hemolytic anemia. This is a very rare B-cell lymphoma, and it accounts for only 1% of all non-Hodgkin's lymphoma in adults. So let's dive right in, and let me introduce you to my patient. This is Mr. X, could be the husband of Madam X. But then, Mr. X presented to me with 2 weeks history of breathlessness and lethargy. On examination, he was pale, he had icterus on his sclera, and also he was tachycardic at 100 beats per minute. So we did an abdominal examination, and splenomegaly was found at 15 centimeters. So we confirmed this with an ultrasound abdomen, and we found out it was 22.9 centimeters. This is massive splenomegaly. Now, we did a serology testing, and we found a prior infection to hepatitis B. And this is important because we didn't have hepatitis C, but we had hepatitis B prior infection. This is because it's very important. It affects how we treat Mr. X. Now, we did an autoantibody IgG and anti-C3d, both were positive. This champions the diagnosis of mixed autoimmune hemolytic anemia. Remember, rule of thumb, splenomegaly can't exist, is not expected in idiopathic autoimmune hemolytic anemia. It's only mild splenomegaly. So if you have a massive splenomegaly, our thoughts should go to an underlying lymphoproliferative disorder. So what we did a serum-free light chain, and we found an excess of a monoclonal kappa light chain. This strongly suggests a theory of an underlying B-cell malignancy, but this was not enough. We ventured further. We did a bone marrow aspiration, and we found white cells with lymphocytes containing cytoplasmic villus projections. Just remember one thing. The presence of this is not diagnostic of splenic marginal zone lymphoma. But this was not enough. Why? Because bone marrow aspiration is not the only diagnostic tool for splenic marginal zone lymphoma, and it's not enough. So we went in more. We did a trifine biopsy, and we found that the cells were positive for CD20 and CD79A, negative for TDT, negative for CD5, negative for CD23. But is this splenic marginal zone lymphoma? No. Why? Because other B-cell lymphomas can present with the same immunohistochemistry. And the microscopic appearance was sinusoidal pattern of infiltration. This can also be seen in other B-cell lymphomas. So this is not diagnostic of splenic marginal zone lymphoma. Confused? I can see a lot of confused faces. Let's move on. Now, let's talk about the blood workup. Please pay attention. The yellow rows represent blood parameters which are affected by splenic marginal zone lymphoma. The light blue, now it looks white, it looks light blue there. So the white rows represents the blood parameters suggestive of active hemolysis in autoimmune hemolytic anemia, and the dark blue represents blood parameters affected in both splenic marginal zone lymphoma and autoimmune hemolytic anemia. Please keep in mind, splenic marginal zone lymphoma presents in 3 criteria. Number 1, massive splenomegaly, present in Mr. X, right? Second, peripheral lymphocytosis, which you can see here, is elevated twice the normal range. And the third one is pancytopenia. As you can see, hemoglobin, red blood cells, platelets are all affected, but white blood cells are not. So let's move on. So let's talk about splenic marginal zone lymphoma. What actually is this disease? Now, this is the secondary lymphoid follicle, which is contained inside the spleen. Okay, this is the anatomy of the spleen. For those of you who are confused, this is not an alien. Now, secondary lymphoid follicle contains a germinal center, which is the innermost core. The mantle zone, it's called the mantle because it envelopes the germinal center, and the marginal zone. So this entire Bollywood story goes on in the marginal zone. that is what the topic is today. So the B cells expand this zone and then obscures the mental zone, obscures the germinal center, and after it has obscured the entire white pulp, it goes into the red pulp. As you can see here in the HNE staining, this is the white pulp, and this is the red pulp with the malignant cells there on HNE staining. Now, picture B represents the lymphocyte with cytoplasmic villus projection. The presence or absence of this, like I said, is not diagnostic of splenic marginal zone lymphoma, and it is only present in 15% of all splenic marginal zone cases, and my patient is one of those 15%. Keep in mind, splenic marginal zone lymphoma is a diagnosis of exclusion, meaning you bring together clinical features, you bring together immunophenotyping, and you bring together bone marrow histology, and you put them all together and you make a diagnosis. But in modern day now, we don't do spleen histology anymore. With these three criteria, it's enough to make a diagnosis. So let's move on. How did we come to a conclusion of mixed autoimmune hemolytic anemia? These are the parameters suggestive of hemolytic anemia. Now remember, literature has suggested that in all cases of splenic marginal zone lymphoma, it normally manifests as autoimmune hemolytic anemia in small population of elderly patients. That is why we prioritize the possibility of this being autoimmune instead of drug-induced hemolytic anemia or other causes of hemolytic anemia. So what we did an autoimmune test, which is the Coombs test, and it was positive. So now we know this is autoimmune, but we have to decide whether it's cold or it's warm, or it could be mixed. Why this is important? Because how we treat our patient varies. Now, we did a monospecific direct antiglobulin test, and we found out the warm component, which is the autoantibody against IgG, is positive. So warm autoimmune hemolytic anemia is present. Now, we did anti-C3d, and it was also positive. This is the cold component. So both are present. So we arrive at a diagnosis of a mixed autoimmune hemolytic anemia, which is present in only less than 5% of cases of all autoimmune hemolytic anemia, and my patient is one of those cases. Now, there are three compartments in treating my patient. Compartment number 1 is the splenic marginal zone lymphoma. Compartment number 2 is the mixed autoimmune hemolytic anemia, and compartment number 3 is the prior infection to hepatitis B. And unfortunately, there is no gold standard or standardized treatment, but this therapeutic algorithm will help you solve some issues. If WHO suggested that if the patient is asymptomatic, it is best to go for option A, wait and watch. In my patient was fits criteria 1 and criteria 2. So we could have opted for splenectomy, but patient was not keen on surgery. So now we are left with rituximab monotherapy or rituximab with chemotherapy. But now, since my patient did not fulfill criteria number 3, we went with rituximab monotherapy. So rituximab monotherapy is an anti-CD20 monoclonal antibody which acts on the B lymphocytes because they present the CD20 antigen. So they act on it and destroy it. So we gave my patient rituximab at a dose of 375 milligrams per meter squared weekly for 4 to 8 weeks with a maintenance dose for 2 months, every 2 months for 1 to 2 years. And keep in mind one thing, rituximab can cause a flare of hepatitis B virus. That is why, in my patient as well, we have given him tenofovir 300 milligrams once daily until he has completed his entire regimen treatment of rituximab. The beauty of this drug, I'll tell you one thing of this drug. This drug has two components. It has a component that acts on the autoimmune hemolytic anemia as well. However, it has a slow onset. So to treat the mixed autoimmune hemolytic anemia, we have given my patient prednisolone 1 to 1.5 milligrams per kg per day for 1 to 3 weeks, and then taper down slowly after that. So why we didn't choose chemotherapy is because if you want a faster response, then chemotherapy with rituximab, our CHOP or our CVP regimen would have been your choice. But then again, the outcomes of rituximab and this rituximab chemotherapy is the same. So here's the question. Do you want to be a good doctor and not put your patient through toxic effect of chemotherapy when rituximab monotherapy does the job? Think of it that way, and that's why we choose rituximab. Now, the importance of maintenance shows here because our progression-free survival rate is better in rituximab maintenance. compared to those without maintenance. Rituximab and splenectomy, rituximab has a better overall survival rate, and this is the dual effect of rituximab in autoimmune hemolytic anemia. As you can see, reticulocytes and LDH went down, hemoglobin levels have elevated. So rituximab works in autoimmune hemolytic anemia as well. So after his induction course, spleen regressed to 7 centimeters from 22.9 centimeters, and you can see Mr. X with all thumbs up and smiles for rituximab, and you can see his entire, when he came for follow-up, this is after he has completed his induction cycle with 1 maintenance therapy, and you can see all his blood parameters have normalized completely. So I know what you guys are thinking. I do sound like a medical rep trying to make you buy rituximab. No, that's not the case. But I believe that if it can work for Mr. X, it can work for any patient. And I champion this as the first line treatment because it does not give us any toxic effects as compared to chemotherapy. It gives us the same outcome as splenectomy, and it has a dual effect on IHA. For that, thank you.
How do you prove this NTC3D test? You say that, what does that test for again?
Which one, sir?
The NTC3D test. That proof.
Yes, that one proves the cold IHA component of autoimmune hemolytic anemia.
How does that prove? How does it work?
Because if those, if the complements are present below 37 degrees Celsius, that proves that those complements, that means that hemolysis happens at a temperature below 37 degrees Celsius, proving that this is cold, happens at a cold temperature.
So you have to take this blood test and preserve it in ice when you do the test? How do you do the test?
I'm not really sure about that. There's a lot of details in that.
Okay. So marginal zone lymphoma, is that a B cell or T cell lymphoma?
B cell lymphoma.
And when you do the bone marrow trephine, explain the difference between that and the other one, which you say?
Bone marrow aspiration. Bone marrow aspiration, you can see the cells, lymphocytes with the cytoplasmic villus projection present or not. But trephine biopsy, you can put it under microscope. You can use immunohistochemistry, and you can see the presence of cells positive for CD20 or CD79A, and you can also see the staining. You can see the sinusoidal pattern. So that's the difference between both. You can't see that on bone marrow aspiration.
Bone marrow aspiration and trephine, is it painful or not painful?
Yes, very painful.
Painful or not painful?
It is painful, but patient is under GA.
Huh?
Patient is under local, sorry.
So how do you make it not painful?
Put the patient under GA.
No.
No?
Bone marrow trephine is not a painful procedure.
Okay.
How can you make it not painful?
Technique?
Yes.
Yes. Well, when I wrote this paper with my consultant, I saw the way he did it, and it was not painful, but you have to, I don't know the technique.
Okay, I'll tell you the answer.
Yeah.
Make sure when you anesthetize, not just anesthetize the skin, you have to inject you the periosteum, anesthetize the periosteum at the same time. Yeah?
Okay.
If you just anesthetize the skin, when the needle goes to the periosteum, it's very painful.
Okay.
So you need to know you have anesthetized the skin
Okay.
and the surface of the bone, then it's not painful. Yeah? So it's not a painful procedure as long as you do it correctly.
Thank you, doctor.
Thank you.
I was expecting that question, but I did not look into the financial thing of it. Yeah.
Congratulations for your TED Talk.
My what talk?
TED
Oh,
Talk.
TED Talk. Okay.
Could you perhaps tell us some side effects about the treatment of Mr. X? I'm sure although he said thumbs up, there must be some potential side effects that you would expect from this treatment.
Multifocal encephalopathy you can expect with rituximab treatment, but the patient has to have SLE first. But if the patient does not have any underlying comorbidities, then rituximab has a minimal side effect.
But Mr. X looks like he has lost a lot of weight. Okay, thank you.
Thank you, everyone.